Okay, so RMH services rehabilitation plan training. So, rehabilitative mental health, RMH services define. So this is through Medicaid. RMH services include basic skills training, BST, program for assertive community treatment, which is PACT, day treatment, peer-to-peer support, also psychosocial rehabilitation, PSR. When I started working in the field of mental health almost 16 years ago, I started as a PSR worker. So I'm very familiar. Also, Miss Donna, you have experience?
PSR, BST.
Yes, PSR, BST. So crisis intervention. So it's very important to be ethical and adhere to Medicaid policy and procedure and be compliant. That is one thing that I take pride in with WC Health, is that our clinical director and leadership are very adherent to Medicaid policy and procedure. And out there in the universe, I was talking to Donna on break that it's the wild, wild west out there. So we want to make sure we are staying in compliance. So mental health and substance rehabilitation assists individuals to develop, enhance, and or retain psychiatric stability, social integration skills, personal adjustment, and or independent living competencies in order to experience success and satisfaction in environments of their choice and to function as independently as possible. So RMH services are rehabilitative. So does anyone know the difference between rehabilitative and habilitative? Anybody? You can do your best guess.
I'm sorry, I had to open the door. I couldn't. I don't know what you asked.
What is the difference between rehabilitative services and habilitative services? Any
Is
guess?
it? I'm sorry, they're loud. Let me close the door. I'm sorry.
Anybody want to put an answer in the chat?
Habilitated means you're already free of disease, and then rehabilitation means you're going through it. Going through.
Close. Anybody else want to take a?
Okay. Same question.
Yes.
So would rehabilitative mean retraining on something? And habilitative is basically you're in that process now, and to rehabilitate somebody is to redo, kind of like bad example, but a good example. The jail system was set up for rehabilitation to get people back acclimated into doing things that they were previously doing in a good way, in a positive way. Is that what that is?
So rehabilitative is someone has lost something, right? They were functioning at a certain point, and then mental health crept in, or a substance use disorder, right? And their ability to function had decreased. And then we apply services to help them rehabilitate back to where they're at. Habilitation is for individuals who they may have rehabilitated to the point of functioning, and now they're at their baseline, and they're not able to go any further. right? So those are clients who may be in group homes or have a TBI, right? They have an injury and they unfortunately can't get back to the functioning that they were at, right? So they need just habilitative services, which is kind of just meeting them where they're at and acknowledging that there most likely will be no more progress. Yeah, that one's tough. And so you may hear as a case manager, right, that a client is not appropriate for therapy, right? And that would be some of those individuals who are at their baseline, and due to their diagnoses, that's where they're going to stay, right? So they're not able to process or make connections or link emotions to feelings or be able to learn skills, right? If they have short-term memory loss or Alzheimer's, right? Like we were talking about, they're not gonna, their inability to learn new information will prevent therapy from being able to be beneficial to individuals and those who qualify there, who meet criteria. So admission for treatment and RMH services, right? It has to be prescribed by a clinician. And again, at this time, WC Health is not currently providing PSR and BST. We have in the past. And are you guys familiar with any agencies in Vegas who do? Shanita, maybe?
I believe, I can't think of the name offhand, but I have seen some reach out to me for on LinkedIn to do those type of services. I can't think of the name of the companies off the top of my head, but there are a few that certain other individuals that was in BST PSR that came from that field to WC Health in that same capacity, but I can't think of the names offhand.
That's all right. Here in Reno, Vitality Unlimited, they do, but what happened, our clients need to get wraparound services there, so they need to be assessed for case management there. And it's, most times agencies prefer that the clinical is done on site as well, and then the RMH services, because there needs to be cohesive communication with the treatment plans. So we can refer out, it just does make it a little more difficult. So the therapist will create a general RMH goal, right? And the RMH staff will develop detailed goals on top of that and objectives to restore the patient to the best possible functioning level. Right, remember, because they're rehabilitating. RMH interventions occur concurrently with clinical treatment and begin as soon as clinically possible. So the therapist of record would refer a client to RMH, BST, PSR, and then we're fortunate enough to have a PAR department, a prior authorization department, which is Miss Brooke Garrett in Las Vegas. And she writes our PARs for individual therapy. She also writes them for IOP, right? Intensive outpatient program, also for TMS as well, the transmagnetic stimulation treatment that we do, or first person does at this time. All right, so the assessment, right? So a QMHP, a qualified mental health professional, is the one that needs to do the assessment. So that would be at WC Health, our social work clinical social workers, including interns, and then we also have some marriage and family therapists, license and or intern, and then we also have the LCPCs, which is the licensed clinical
Psychologist.
professional counselors.
Oh, professional counselor, yeah.
Yeah, and intern as well. So at WC Health, we do the AMA, which is our psychosocial assessment. And if the client is a minor, it is the KUMA. So, and some people call it the UMA, but I call it the AMA. Shanita, I see you laughing over there, girl.
Yeah, like I said, I worked in therapy for a long time here as well as MCAT, and yeah, the UMA was a lot.
I think that's a
Or
salad.
the AMA or something.
In Reno,
Someone
we
else used
call
to
it
call
the
it.
AMA, and I think in Vegas, I've heard it the UMA. I don't know. Nicole,
AMHA is what I've heard. AMHA.
AMHA. I don't know. I call it the AMA. But the psychosocial assessment is what I'm communicating, right? And there could be miscommunication right there if we're calling it the UMA, the UMHA, the AMA, right? What are we talking about, right? We may need to clarify with our colleagues if we're talking about the same thing. Okay, so it's a comprehensive evaluation of the client's history, functioning, which combined with clinical judgment is to include the current diagnosis, right, from the DSM-5 TR. I have it here. So this is what we use as our diagnostic statistic and statistical manual of mental health disorders, right? So the qualified mental health professionals will be the only ones doing that. And if clients are looking for a substance use evaluation, right? Have y'all heard of those ones? So we do not do those here. We only do psychosocial assessments, and we can diagnose for mental health and substance use disorders. But if someone is diagnosed only with a substance use disorder, then we would refer out, right? And if they're looking for a substance use evaluation, we would refer out because we do not complete those. And then for Vegas, I know we have a list in Reno of where we refer out. I don't know what that would be in Las Vegas, and Miss Audrey isn't in there on the call right now.
What place you said? What was that you said? What place?
In Las Vegas, I do not know.
No, I'm asking. I didn't hear the question. I have people in the room with me now.
Referring out for a substance use evaluation.
I have reminders. Like they send reminders.
Oh,
Okay, well,
maybe Crossroads or Seven Hills or something like that.
Who only treats substance use.
Friday at 3.
Yeah.
So we'll follow up on that. Okay, and then health and behavior assessment, right? We're going to identify psychosocial, behavioral, emotional, cognitive, and social factors important to the prevention, treatment, or management of physical health needs. So we're also assessing to see if they are connected to primary care. Luckily, we have our partnership with First Person who we can refer to, right? And ensure that appointments as a case manager that you would make sure they are linked and have appointments, and ROIs could be filled out, right? So there could be some communication there because it's no longer, and that information isn't in our EHR services anymore. So this assessment has to be completed in order to establish care for any care, right? And the clinician either admits a client for our services or does not. It's actually a checkbox on our assessment, and begin therapeutic services. And then the clinician makes a clinical recommendation, right, of what services that the client like their level of care. PSR and BST training service. So services must be prescribed, right? The clinician of record must recommend services to be provided. RMH services is an extension of therapeutic services, right? So therapists must prescribe the level of care. That is done through the locus and the CASI for minors, and address specific needs of the patient when inputting the request, right? This client could benefit from RMH services because, as evidenced by, is a lot of verbiage that we've been using in our documentation. Okay, this is what I'm recommending. Why am I recommending it? How can I clinically justify that an individual could benefit from this, that they could be rehabilitative, right? So Medicaid will also, like if someone has autism or neurodivergent diagnosis, a lot of times Medicaid insurance will deny RMH services because that individual, like that diagnosis is right. They don't see that as rehabilitative. Also, if someone's being referred for PSR, BST, I have gotten denials in the past where a client could benefit from a lower level of care, which would be individual therapy. And then if someone's getting PSR, BST, IOP, group therapy, right, they have to be connected with a therapist within 30 days. Yes. And that's why we have a wait list, right? It is so unethical to assess a client for therapy and then not see them for therapy. I know there are some agencies out there that they would assess people and then put them on the wait list. No, that is so unethical. How are we going to clinically justify how this client needs these services and then not provide them? So the wait list is more ethical to be assessed, not assess them and then be put on a wait list. That is very concerning. We don't want to do that. So basic living skills. Do you want to do the slide?
Okay. So basic life and self-care skills, social skills, communication skills, organization and time management skills, transitional living skills, and parental training skills. These are all tools that you use. I used a lot when I work with children, because a lot of kids just, parents don't think about things, and as parents, you're kind of just trying to get day to day. And so when they come in to do BST, you set up, okay, so we know in the morning we're going to get up, our alarm is going to go off and work. What are we going to do? We're going to get our food, we're going to eat, we're going to do, and just try to get them to where they felt manageable in their own time. Because otherwise they're sitting around, maybe they pull their video games out, and you just kind of redirect them to, okay, we have a time frame. We have to leave the house by 8 o'clock to get to school on time for 8:30. So we're going to get up at 7, and just giving them guidance to help them feel like, okay, this is still my life, but I'm just getting the skills to be able to have my own control on it, my own time frame. I'm doing this where I need to do it. If I know I need to be up at 6:30 instead of 7, that gives me time to play a little video games, do whatever I need. And then by 7 o'clock, I'm ready to hit the ground. And you just give
Mm.
them these skills to make them feel that they are still the protagonists in their own life, but sometimes they just need guidance to how to get there.
To help them with implementing structure.
Structure, absolutely.
Yeah. Anybody else have any wanna chime in? You've got some background noise.
Yeah, that's why I'm muting his people talking.
Yes. Okay, yes. So there's some background noise, but I know Shanita did want to. You could also type it in the comments too. As well.
Oh, okay.
Some activities that we can utilize, communication skills. I used to work with adolescent males in foster care, and I would take them to the community, and we would go to the rec center, like the neighborhood rec center, and they would have to check in with staff, right? And give the individual their name and being able to articulate themselves and advocate for themselves and how to play football with their peers without getting in a fist fight. Yeah, those were the days. I spent many hours at parks. Yes. In the city of Reno and Sparks. Many hours entertaining adolescent males on a budget of $0. I have come so far. Okay, PSR, psychosocial rehabilitation skills. So this one is those who are providing PSR have a I believe a bachelor's degree with a certain amount of credits in more of the psychology, sociology, human development, and also criminal justice counted
Oh, wow.
fairly.
That's impressive.
Oh, wow. So the little one advocated for herself. Is that right, Shanita?
Yeah, the little girl was great. Sorry, I jumped back. I was trying to type, but we got a delay in the internet here. I only have one child. She was really self-sufficient, very smart, very knowledgeable young lady. She was really good, but she did have some traumas because of her mom's trauma. So I convinced her mom to not only have her daughter getting help, but to get herself help because she was dealing with a lot of childhood traumas for herself. So she ended up doing it, and I ended up transferring her over to Tanya because Tanya was PSR. Because as BST, they wanted me to meet with her twice a week for 2 hours. As PSR, they gave her both. And as PSR, they wanted her to meet with the PSR worker. And my perspective on that was that's too much for a child. That's way too much for a child. So since PSR can do BST, I just transferred her over to Tanya to work with her, and it worked out that way.
Aw. So looking out for the best interests of our clients.
Absolutely.
Beautiful. That's very important.
And the parents sometimes.
Absolutely, right? And if we can help the parent, right, then by helping the parent, they can help themselves, which then trickles down to their children, right?
Absolutely.
And for example, here at WC, how a lot of if I have clients who have children, and we really don't have many people who see children here, making sure, right, if they're having a tough time, I have a client yesterday. She was in, and her daughter's in therapy. Her daughter is 4. And I'm like, oh, well, did you use the recommendation given by your child's therapist? She's like, well, not yet. I'm like, well, but building that rapport that you're taking the suggestions and you're applying it, right, while working with your daughter can also give some buy-in to the therapist, right? And actually, I wonder, I'm going to have her sign a release so I can talk to her daughter's therapist and see if there's anything on my end that I could tease out with my client. And that's called continuity of care, right? So behavioral management, social competency, right? With adolescents, I would always say, hey, who are you befriending, right? Like, are you just allowing people to put stuff in your backpack? This sounds a little odd. Problem identification, right? It looks like you're always late to PE or you haven't been dressing out, right? Like, what could we do? Or it appears that the family conflict arises on the weekend, right? What's going on there, right? So really just taking a step back and looking at it from an outsider's perspective. Also, what the PSR worker is doing is going to be goals listed, identified by the therapist, right? So it's a united front. Yes. And then because the therapist isn't working one-on-one with the client for, 4 hours, 6 hours a week, right? The PSR worker and BST actually get more insight than the therapist per se. It's a different perspective. So the importance of communicating with one another is very important. 1 second, my phone. Okay. Effective communication, which we did a whole presentation on that recently. Moral reasoning that meet the client's morals, right? Everyone has their own values, morals, and ethics. Identify and emotional reasoning, right? What emotion were you feeling? Well, what emotion and why did you act out on that? Being self-sufficient and life goals. So, just in case. So, RMH services, insurance does not pay for custodial care. We're not babysitting. We're also not supervising appointments. It's not case management, linkage, care plans, transporting. I don't know how many agencies you worked at where driving a client to point A to point B is not a billable event. We're not doing that. Paying for the following: room and board, food expenses. You're not paying for things, education, vocational, and academic training. Definitely what you could do is create goals as a PSR worker and then encourage work on communication skills for calling the vocational rehabilitation agency or that sort of thing. So it's very particular on what the services are covered with RMH and what isn't. You're not treating the entire family, but you can also give parental suggestions to the parent, but we're not treating the entire family. And it doesn't include gambling disorders as well. Okay, so there are 6 levels of care. Locus, the level of care utilization system. So this has to be completed every 90 days by the clinician connected to the client. And yes, And I don't think at WC Health, the case managers do the locuses, the therapists do. Must be completed by a QMHA, not a by a QBA. And so locuses must be completed after an in-person contact. And it has to be completed every 90 days. So we don't want to do it within the 90 days for reimbursement purposes, but we usually do a day counter and then do it exactly on the 90th day, and then assess for level of care. So there are 6 level of cares, and level 2 would be for BST, and level 3 and 4 would be considered PSR services. Does that look about right? Audrey, Shanita, Donna?
Absolutely.
You're muted.
Thank you. Sorry about that. Yeah, when we're talking about these levels of care, it's typical that 3 or higher necessitates the RMH services,
Yes.
as well as targeted case management.
Thank you. The Cassie, I'll get you a little more situated. So child and adolescent services, right? Intensity instrument. So this is for minors. Again, it has to be completed every 90 days by the client's therapist. Must be completed after an in-person contact. So 6 levels of care, right? So these are very similar to the locus. However, on the 6 criteria, there's scale A and scale B. And so whatever you're rating the adolescent's involvement in services, and then you rate the parental guardian caretaker involvement in services, and whatever one rates higher, that is the one that you count in the Cassie score. That was definitely a learning curve for me in this profession.
Awesome. And then this goes into the levels of care for the RMH services. So when following and being compliant with Medicaid, the intensity of needs level 3 is a maximum of 2 hours per day. And then 4 and 5 is a maximum of 3 hours a day, and 6 would be a maximum of 4 hours per day. It's really important that you are aligning with what the PAR from insurance states services to be, and that we're aligning with that level of care.
And again, so RMH is also person-centered planning, right? So pretty much everything we do at WC Health is person-centered approach, right? And evidence-based practice shows that this approach is most effective. All treatment planning should take a person-centered approach, right? So we're going to tap into their strengths, what they're wanting to work on, right? It's not what we are telling them they need to work on or they have to work on, right? We're meeting them where they're at. And then that way, that when the client, it increases their willingness, right, to engage in services and actually benefit, have long-lasting benefit from the services we provide.
All right. So the PAR, this is a prior authorization request. Here at WC Health, Brooke Garrett is the PAR department personnel. I'm not getting her title right.
Supervisor.
Supervisor. Thank you. And she works with a ever-growing team. And so when when we submit these requests for services, or these recommendations rather for services, Brooke and her team submit the PAR. So this includes RMH, therapy, group, all of those all those services, and it's a formal written request submitted to the health plan for approval. Each health plan is different in what they will approve, and the length of time that it takes to approve is different for each plan. The PAR writers are responsible for submitting the request in a timely manner. Typically, a response is provided within 14 days. And then once approved, providers are able to provide those services according to what has been agreed upon and approved. So these PARs can always be found in clients' charts, and or you can always reach out to Brooke Garrett for any questions about PARs.
Yes. And just like the services we provide, right? We serve those who have severe mental illness, right? SMI or SED for minors, and ensuring that that documentation is updated annually in the chart, right, is the clinician of record's responsibility. And I have gotten emails from case management like, hey, this hasn't been updated. We're like a week out, right? So always communicating as a team that everyone's got what they are responsible for in the client's chart, so we can continue to be compliant with Medicaid, right? And that's talking with our care plans and case management and the needs assessment, right? Like how important that is, because one thing, if it's missing, right, and if I don't do my 90-day treatment plan review, then the chart is out of compliance, right? And we're not adhering to the standard, the high standard. So it's very important.
Yes.
You did that one. My turn. Okay. So what makes a RMH treatment plan? So objectives, right? So these objectives are going to be based on what the specific goals the clinician has recommended. And so being specific and measurable actions that can be reached in a short amount of time, right? So again, that would be created with the client. Like, how on earth are we going, what are we going to do and be able to measure to indicate that you're working towards decreasing symptoms of depression, right? Where I'm not laying in bed all day, right? Long-term goals, the desired outcome from the client receiving treatment, the end goal for the client to achieve desired success for the client's future, right? And their goal may be very different than what we would think their goal should be or has to be, needs to be. Again, how do they envision, their life, right? And their future. Short-term goals, often within 90-day increments, right? This is more, again, a SMART goal. Has anybody heard of a SMART goal besides myself, Donna, and Audrey? No. And those are just being more specific, measurable, attainable, realistic, and time-bound. So it's definitely it's an acronym. And now, right, a lot of in order for it to be measurable, it would need to be a SMART goal.
So treatment plans. This is related to RMH. Also, to case management, this is the needs assessment that y'all look at and that you do. That is a type of plan for progress and how we are measuring client progress, how we are able to kind of tie in documentation. Hey, these are the things that we did today with the client that relate back to that needs assessment, the goals that they have that they're working towards, whether that's vital documentation, whether that's independent housing, employment, all of those types of goals that our clients have. So the initial treatment plans are completed by the clinician. When I did PSR and BST, we had worked off of our treatment plan was off of the therapist treatment plan. So the therapist would be processing and exploring. That was not the same scope that we worked in as RMH workers. We would be supporting that skill use, right? So maybe looked a little bit more like encouraging the client to utilize those skills that they were learning in therapy and being able to support them through that practice. And then it's WC Health. When we have done RMH services, the RMH provider has come up with their own treatment plan with the client to be working on goals. And the treatment plans are really how we can justify services, why it's necessary. And like I had said, it really links in the work that we're doing. We have to be able to relate it back to the treatment plan. And sometimes we might get stuck in a treatment plan, might get stuck in progress on a needs assessment. It's a really good time to reassess and kind of run through that SMART acronym that Natalie had gone through. Are we being realistic with the goal? Was it ever achievable for a client to get their documentation in 2 weeks, right? And most likely no, because of how those processes can be stretched out. So we can always go back and revise that with clients.
And then both the provider and the client would need to sign these, right? And there are no exceptions, as this is a Medicaid Chapter 400 rule, right? It's a mandatory. They're non-negotiable, is what I would like to say. So right now we're gonna take a break, and we will reconvene at 10:20. Hi guys, I was just introducing myself to a MSW potential clinical intern. So, whew, ebbing and flowing. Right. RMH treatment plan. So again, when RMH services are provided, it is based on the treatment plan. So we want to have like that golden thread. People come to our agency, WC Health, seeking services. We identify their strengths. We identify what they're experiencing. And then based on that, we create a treatment plan with the client, right? So there's this cohesion. And then anything that we do, our progress notes as case managers or therapists, we're linking it back to our care plan and to our treatment goal, right? Everything that we do is documented and it all aligns. And if we ever get lost, that's what I love about treatment plans, care plans. If I ever get lost, I always refer back to the treatment plan. I'm like, what were we doing? What was our goal? Like, oh yeah. And it always grounds me. So a client too, right? If you're just like, oh, I don't know what to check in with them about, refer back to the treatment plan, care plan. We have that document and it's leading, right? It's guiding all of us.
Yeah, the way that too I learned about treatment plans and kind of getting oriented to them is they're a living document, right? So meaning that they can always be adjusted, they can always be added to. You know, a client can really come to us and say, I don't want to work on this goal anymore. It's no longer relevant or important to me. So they can always be amended. They're living documents.
Yes. And again, if we're working with a minor, right, this is going to be created with the guardian or the parent, and they're going to sign it.
So updates, right? Every 90 days is that guideline that we complete updates, note progress. So at a minimum every 90 days, but it can always be done prior to that. And what's needed, you have to be seeing the client to be able to update or change the treatment plan in any way. Also that update for the locus or CASI score, prior authorizations are also completed and submitted. And then with the 90-day updates, there's documentation in that narrative format to support any updates. So whether or how the client was able to meet their goals, our observation of progress, and how can we back that up. So it's not just, yeah, client appears to be making appropriate progress. How can you substantiate that? How do you know that? What is the justification for that? What are the things that you're doing to work towards that progress? And then the plan on how you intend to help the client meet their goal in the next 90 days. And then updated measurable goal for the client to meet it over the next 90 days.
Progress notes. So again, important documentation. It's important to document all forms of interaction with your client. That could be phone calls, leaving a voicemail, sending an email. Any attempt to contact, right, should be a contact note. Missed appointment, no show. I know the therapy department, we have a no-show note, and just documenting that. Does case management? Yes?
We don't have a no-show note over here that I know of.
Yeah. And I think because you can reschedule the appointments. I'm not quite sure on that one.
So here we make it a point to notate no show for appointments for accountability, because a lot of times they say, oh, I was supposed to be scheduled an appointment or I didn't get notification, but we send them out a case management appointment letter like days in advance. So again, it's accountability.
Yeah. And how do you document that?
So I just put in there HMIS and what's the other? I'm still new to this. What's the EHR and EHR. I put them in both.
Yeah, that's awesome.
Thank you.
You're welcome.
Also important to document a discussion regarding risk of discharge and acknowledgement. I always tell my clients, like, hey, if we're 15 minutes late to therapy continuously, like, do we need to reschedule a different time, that I won't be able to see you next time? And I document that, and then that will be considered a miss. And if we have a certain amount of misses, then we will have to close services. And in that circumstance, when we provide PSR services, that means they would be close to those services as well, because they have to be open to therapy in order to receive PSR BST. And quality of care and reduce risk of abandonment. I have a client that I met with yesterday who I wrote the emotional support animal. She was like, I think I'm good. I think I'm okay. My anxiety, I think I can manage it. And I was just reading our therapy manual, and best practice would be to create a care plan with her. So what I'm going to do is the next couple sessions is create a care plan so she could have a living document of what she can do if her anxiety increases after she's closed to therapy, because I was like, we do have a large wait list and you won't be able to just get on my schedule quickly if something happens. So I'm going to be documenting that we are going to create a aftercare plan and document that for best practice.
So in the progress note, which Kate Westfall does do documentation specific to case management in the format of that. But to review for RMH progress notes, these need to be completed within 24 hours after each session, and that is a Medicaid requirement as well as an agency requirement that we are doing timely documentation. That's best practice, best care that we can provide to clients is also making sure that our documentation is up to date. You bill for the correct number of units associated with the number of hours. Every 15 minutes is considered a unit. So 1 hour session, 4 units, 2 hours, 8 units. And when a patient is approved for services, the health plan typically will provide a start date and end date. So we cannot start or end services outside of that time frame that the health plan gives to us.
Again, so the task, right? What is the goal that you will work on today? CM or RMH worker worked on goal number 1 with client at this location. What interventions will you use to help the patient with their treatment goal, right? We'll work on active listening skills, right? If the goal is communication, what is the objective or purpose, right? What will be the intervention that you use? Action. So what we want to do is describe how the patient presented themselves, right? Were they engaged? Were they interacting? Were they compliant or, invested in their time with us? Behavior, right? I could say, oh, their hair was really unkempt. They didn't style it when usually it's very pristine, and they are very intentional with the way they present themselves, but not today, right? That could be an indication that maybe their depressive symptoms have increased. So if we're putting that in the action and the therapist or the psychiatrist read those notes, right? Because what I have found is I communicate with psych providers without even knowing it, right, through my documentation. So really, all of those details matter that we do put in the note, and to individualize our notes, because I can, to the person, right? I know we need certain criteria for our documentation, but also to personalize it, right? If I'm looking at some notes, I'm like, oh, this looks very similar. Like I've seen this in every chart before, right? Like, what are we doing? Also, I know that we have a lot of documentation to do, but being mindful of that. Second intervention, did it align with the treatment goal? What was the objective? How did you help the patient with the lesson, right? What feedback, encouragement, right? I love this clinician encourage client to implement or provided positive feedback, right? So we want to encourage our client to make progress or to increase their self-confidence that they can do what they have identified while working with us.
Awesome. And then the conclusion, this describes the client's progress or lack of progress towards a goal, right? So if we're noticing regression, how can we also support that? So not just being able to support what progress is being made, but if there isn't progress being made, identifying why, or how we can support that. What did you observe? Write what you saw and heard that supports your observations. Do not make judgment or statements unless you can back it up with specific observations, right? And kind of what Natalie had said on Monday. Writing our notes as though the client is viewing them is a really good framework to stay within. It can help us stay out of that non-judgmental. There's also qualifier words that we can use, such as appears, seems. That can be really effective when we're making some of these statements about progress. You know, client appears to be making progress, as evidenced by appropriate engagement with use of skill during session, right? So that can be how we kind of qualify what we're documenting. And then lastly, what other behaviors, remarks, or mood stands out in regards to the patient's progress or regression? You know, appears to be reluctant to engage with redirection during session, appears to be making minimal progress as evidenced by tardiness to session, or appearing to be resistant to feedback during session, right? So being able to qualify that. And then the follow-up, what did you do? What intervention will you use? Which interventions will you use in the future to help the client achieve their goal? What's that plan going forward?
Okay. Remember, we never use I or me or the name of the patient due to transitional living, right? Like they are clients. I don't know about Sana, if you guys use patient,
Resident.
resident. Thank you. And then I know for myself, I use client because I have worked at a hospital before and they are not my patient. I'm not a doctor, but I I use client. But yeah, so it depends on what location you're at. So I think being mindful too of where you are, what your role is, and how you are going to identify the client. And then for me now, I used to use this writer in the beginning, and now I have now I use this clinician. So I have kind of switched up how I identify myself. Do you guys use CM? Yes. Way easier than typing out case manager, right? Yeah, I'm CM, and it's very it's a buzzword and we know what it is, right? So in our documentation, right, we observed, we redirected, practice, utilized, educated, discussed, linked. Does anybody have
Monitored. That's another big
monitored? Yes.
monitor. Medicaid likes that one.
Any other ones that you guys use?
A lot of times I use the monitor, like you said, but in my conclusion, I'll say CM will monitor and follow up with clients with progress and updates.
Nice.
And progress related back to their care plan. Right? We're linking it back to what we are doing, right? Because anything in case management, and that comes from the care plan is created from the needs assessment. So everything aligns. And I can say, you know, we're human. And when I'm assessing a client and I diagnose them with certain diagnosis, and then I create the treatment plan, I have been guilty of making treatment goals that didn't align with the diagnoses, the presenting issue. And a lot of that could have been client driven. but also like redirecting and making sure that we're doing this golden thread, that everything aligns. And I don't know why it took so long for me to finally see this. But I was like, oh, right. And I've worked in chapter 400 for almost 16 years, but it's a lot of information. And asking questions from your supervisor, right? If you're ever feeling lost, or am I documenting this right? Am I documenting that they're making progress on the thing that I'm supposed to, right? Always ask questions. There's never a dumb question. And if anyone gives you feedback on how you can improve your documentation, please don't take it personal. It doesn't mean that you're not a good case manager and you're not doing good work. It just means that we can document what you're doing in a more effective way. Yes. So below is inappropriate note, right? It has I and the client's name. So we're not going to be doing that.
Okay, so this one's a little bit of practice. Want y'all to read through this scenario, and then we can hear from volunteers how you would word this into a note. So give y'all just a couple minutes to read through this one. All right, and can y'all send in a thumbs up or show a thumbs up once you finish it? Sweet. Yeah, Nicole, question? You're muted.
Oh, sorry. I thought that was a thumbs up.
Okay, there we go. Tanasha got it. Oh, there we are. Love it. Maybe just waiting on Angela and Jeanette. If the two of you have finished reading through it, go ahead and give a thumbs up. Okay, saw Jeanette's thumb up. Awesome. Nat, can you roll forward, please? Thank you. Okay, so does anybody want to share theirs before we see an example of how this is written? How would you have created a progress note based on that client interaction?
Are we taking some time to create one?
If anybody has it, do we need more time to look back? We can go back to that scenario if people need more. Okay, let's go. Thank you for the feedback. Let's go back to the scenario, and Tanasha, if you have it, you can share it with the group.
I was just saying, initially, I would acknowledge her issues that she's been struggling with the anxiety of going into certain places. And then I would break down the steps to reduce it and how I would coach her on that. First, it would be like they said, go to the setting, observe her, and then notate the skills that she needs to reduce it and then bring to her attention what makes her anxious, because it's important to have them involved as well. And then just continue to go to the store. So this day we worked on this. We noticed when you first went in, you became anxious. What triggers you? Is it the amount of people in the store? So maybe suggest you go earlier or later when there's not so many people there. You know, give options. Let's see. And maybe it could be like a let's see, a self-conscious thing. Maybe she has issues with. They may have issues with counting money, just grocery shopping in general. So when people are afraid of certain things, they choose to, let's say, avoid certain things per se. So just give them the tools to be able to accomplish these certain things. So the first day, maybe just work on being comfortable with the store. Choose a certain store, maybe a smaller store to start off with per se, and then move on to something bigger once they're comfortable. Small things. Just goal setting basically.
Yeah, I love some of those suggestions that you're sharing, the feedback that you would give the client. How would you write that into a note of everything you're saying? This is what the interaction would be. How would you write it into a note?
Several times when assisting client Jane at the grocery store, she was observed, became anxious upon entering the store. Discuss with Jane skills needed to overcome this. One being choose a smaller store versus, like, let's say Smith's versus Walmart, and become familiar with the products they typically shop for, and familiarize themselves so they're not all over the place. So notate where you, I guess, let me rewind. So a detailed grocery list. So we know initially when you first went to the store, you hit the produce aisle. So start with produce first, and then move on to, let's say, snacks, non-perishable, and so forth. So they have a plan of action, so they're not all over the place. So the basic structure.
Yeah, those are really great. And you hit some of those buzzwords, right? Discussed, kind of facilitating use of skill, reminding, encouraging client to use skills, strategies. Really, really good job. Anyone else want to give input on how they would put this into a note?
I had one, I just can't remember because I had a client that I had two BSC clients that had the social anxiety, and we were kind of grouping things together, like couponing, looking for sales, paying attention to things, or, to distract you from all the stuff around, and just like Ms. Williams said, just go into, I'm sorry, I can't pronounce your first name, I forgot again. Go into smaller setting stores to start off, like you said, a mom and pop store, or Walgreens versus Walmart, and slowly, gradually moving on to bigger and more crowds, like gradually, instead of putting them in a big setting off the top. But the note, I can't remember how I wrote my note, but I did use the observed, that provider observed client. Gosh, I could go to her note, but I can't.
Yeah, we'll roll it forward and kind of break it down with everybody. Take a look at this one.
Thank you.
So in this one, the task, right? So, and being really specific with that first part, provider met with patient for an appointment to develop behavior management skills, anxiety. Provider met with patient in a social setting to teach coping skills to manage her symptoms, right? So both of you ladies had identified some of these great strategies, some of these great skills. We can be really concise with it and just say coping skills, because everything that both of you identified, those are coping skills. Those are strategies to support success in that scenario. For the action, Upon meeting with the client presents with high anxiety as evidenced by, right? This is where we get to talk about she was fidgeting, rapid speech and pacing, provider educated. You know, the both of you had mentioned strategized, encouraged, but in this one they use educated patient regarding anxiety symptoms after bringing her behaviors to her attention. Client was observed to be surprised. They use this quote. This is a narrative format. Really? This is what anxiousness means? Provider is able to teach breathing techniques through modeling its use. Patient had to be redirected 3 times during the session, but was observed to utilize the skill on her own successfully once without reinforcement. And then the P is plan follow-up. Patient is observed to make some progress towards her goals, but will need further reinforcement to support her need. Patient is scheduled to meet for her next session on Tuesday, 12/20 at 2 p.m.
Mhm.
And I know on the fly when you're just talking it out, it's different than when you sit at your computer and you've just had the session with the client. So great job, and thank you both for being willing to participate in this.
Yes.
Do we have any questions about how they took the scenario and then put it into this note format?
It looks a lot like what I was taught when I was doing RMH, and that kind of helps a little bit because I'm struggling with the tag notes right now and making sure they're correct. I'm struggling with that right now because it's out of my realm of what I'm used to doing for so many years. So yes, I'm struggling with this.
Yeah, thanks for your
But
own.
as BST, I was able to do this way.
It's different and there's a learning curve with it. And what I have found most helpful in notes is to get that feedback early on so that I don't learn bad habits or keep doing it wrong and then have 20 notes that I have to revise because it wasn't the right format. So I would really encourage Shanita for you to reach out to Juan and Kate. Kate will also do a thorough note training. It's a 4-hour note training. So you can get that really direct feedback and instruction, because I think that's a great thing to want to have a handle on and to know so that you can feel more confident, more comfortable in the documentation piece of the role.
Yes. And those who are hands-on into that and not like a decade out. So I did try to help Shanita out on Monday, and I was like,
Yes,
I am so out of practice. So definitely Juan and Kate will be your support for that.
Yes.
And so remember, every client, right, we need to close their cases, right? Case closure forms are to be completed no later than 30 days following a planned discharge or 45 days following an unplanned discharge. So if we have not met with a client in a certain amount of days in therapy, it's 30 days, then we close to therapy. If clients discharge from housing, right, there's a housing discharge note, and then there's also a case management discharge note, right? Just because someone has left our housing does not necessarily mean they no longer want outpatient services or that sort of thing, or ensuring that they went to the location, right, that we linked them to, because that would be linking and monitoring, at least documenting it once it's done, then to close clients, right? Because if we close it and then they're receiving case management services somewhere else, right? That is best practice. So go ahead.
Yeah, sorry. Just want to add, I think it's really important to have conversations about closing from the very start of working with clients. And this is because we work with clients a lot of times that have a really ruptured attachment style. And so they can really start to become dependent on services that they're receiving. They might even start to kind of over align and really have strong attachments with the providers. And so it's really healthy. It's a really good boundary practice and exercise to be able to communicate from the start of services that the ultimate goal of any of the services is that there will come a time, there will come a point where the collaborative work has been successful. It's accomplished the purposes that it intended to, and that closure is imminent. Closure is a part of that process, that we won't spend the rest of a client's life working with them. In most cases, that is absolutely truth. And so what I found really helpful in therapy services and just in general in mental health services is to have those conversations ongoing throughout your work with a client, so that it doesn't come a day of, hey, you finished all your goals. I'm going to close you now to services. And then it's really shocking, really jarring for that individual. Same thing with the boundaries around, if you miss appointments, you will be closed. If I haven't heard from you for 30 days, you will be closed to services, so that that's not new information for clients.
Yes. What are some possible reasons why we would close out a client? So you can raise your hand or put it in the chat.
They're not engaging anymore.
Yes.
Yep, non-engagement.
They moved.
Mm-hmm.
Not feeling as if they need the services.
Self-determination, right? They can at any time say, I'm good. I don't want to continue. For whatever reason. Definitely.
Incarceration.
Um, some clients, we have to discharge because of behaviors, and we can't see them anymore
Mm-hmm.
for safety reasons.
Yep, they're not appropriate for services.
Mm-hmm.
And I've seen that a lot with some companies. They're just continuously seeing patients. They're seeing therapy. They're not getting anything from it. So it's a waste of time. Why are you notating that you're seeing this client? They're sitting here drawing and doing backflips and stuff during the session. How is that proper treatment? It's false documentation, false billing, because they're not getting anything from it. So I pulled several of my clients from therapy.
Yeah, that's an interesting point that you're bringing up, Tanasha, because I definitely think there is a line with that, right? Of if a client is not benefiting from therapy, that's a really important conversation for the provider and the client to have. And that's maybe where, you can support them when they're coming to you and they're saying, I don't know if I'm getting the most from this, right? That you can help encourage them. Hey, what does a conversation about this with your provider look like? So that there can be that determination between the provider, between the client, or, what does it look like to maybe ask the provider for something else that you're wanting to see in therapy, or talk about, a need for transfer maybe to a different therapist. But I would really encourage, support that to be a client's determination. And I'm not saying that you're not saying that, but when it comes to kind of the rescuer role, that clients can look to us and we're the rescuer, letting them navigate some of those conversations is really important.
And when I was referencing back to pulling clients, when I was more focused on the clients I service with intellectual disabilities that weren't able to self-advocate.
Gosh, thanks. Yeah.
And that would be more of the habilitative, right? That they have met their baseline and they're no longer, yeah.
Yeah.
Good
Thank
job,
you for sharing that.
Tanasha. Yes. This middle question is breaks my heart. Is it appropriate to stop seeing a client if we no longer had any desire to work with them?
Would that be if the client is not engaging with you? Like I have, and I need to ask you about this later, Audrey. Or if you feel like the client is not receptive of you and you guys' training. Example, I'll say, is a therapist working with a client, but they're just not connecting. Would that be something that you can no longer have a desire and want to move them to someone else because you feel like you're not connecting with them and you're not making any progress?
It's a great question. I want to open this up to your peers first, Shanita, before
Come
we
on, peers.
respond. Yeah. What have y'all done in that situation that Shanita's describing where maybe there's personality differences, maybe it's just like not the best rapport ever? It might not be harmful or detrimental, but what have y'all done in those situations?
Uh-oh, nobody's had that situation. Sorry.
And to piggyback off what I was saying earlier, I've had that situation because I've had therapists that just don't want to deal with them because they are challenging and not easy to work with. So they'll just sign them off and just say they're not workable.
Mm.
And that's where it comes back to self-advocating for the client as well. To find them someone more appropriate because they're not getting anything from it.
Yeah, if I could be misunderstanding the original question.
What was it?
From Shanita, are you wondering if a client's telling you the fit with the therapist, or are you saying you personally in working with a client like have noticed that it's more of a challenge, you might not have the best rapport? Are you talking about case manager to client or client to therapist?
No, well, case management to client, if I feel like it's somebody that's not connecting with me, I will talk with the other case managers and see like who feel like maybe they can be a better fit for that particular client. I've had a couple like that, and before even picking them up, we'll discuss like who we think together collectively would work. But in this instance, I'm speaking of a client that I have that doesn't have an issue with the therapist, but just feel like they're not relatable to them per se. But the other thing I was addressing with that question is in perspective of a therapist, if they feel like they are not connecting with someone, I guess it would be the same as case management.
Mm-hmm.
What you're saying, is it appropriate to stop seeing the patient if we no longer have any desire to work with them? I can see, like Miss Tanisha said, turning backflips and doing all you can, and they're still not engaging with you. That would make you feel like you're wasting time with someone who's not being perceptive to what you're acceptive of what you're trying to teach them and passing them on. So that would be a desire to no longer work with them. Not as far as like, oh, she said something out of line to me, so I don't want to deal with her no more. Like Miss Tanisha said, being challenging and you don't want to deal with it.
Yeah. So that, feel free to jump in at any point, but kind of the basis around this. not liking a client would not be a good reason not to work with them. There are going to be clients that for each of us might be more challenging to work with, and there might be clients that for each of us are less challenging. We're talking about implicit bias on this, right? That we all have our own lived experiences. We all have our own biases. It is super important, if you are noticing these things, do have those conversations with peers, have those conversations with your supervisor, to help get support around that, because what needs to happen in those situations is to make that conscious, to make that something that you are aware of and that you are actively working on. And then is the other part of have these difficult conversations with clients. I'm not saying tell your client, you believe XYZ, but I believe this about politics and it really bugs me. Don't do that. But be able to have a conversation of, hey, I'm wondering how you feel our rapport is. I'm wondering how you feel like I am working with you, that we're working together towards the goals that we have. I'm wondering if you think that there might be somebody who would be a better fit. And those are important conversations in case management and absolutely in therapy. As a case manager, if you have a client who's coming to you and they're saying, hey, in working with a therapist, I'm not sure if it's the best fit for me, please encourage them to talk, right? We're talking effective and assertive communication. Have them talk to the provider. There might be limitations around that where they might not be able to do so. We're kind of talking about some specific disabilities that might be more impacting a client's ability to have that conversation. But try to always encourage that. Also, you can support the client in completing what's called a provider transfer request.
Provider change.
Thank you. Provider change form.
Yeah.
Which is their reasons, their justification for why they want to work with a different provider. And that's all providers. That would be psychiatry, medical, therapy, case management, even. But I think you're right on track with, staffings, with having staffings with colleagues of clients. Talk to your supervisor. Talk about what is coming up for you. What might some of those barriers be? Because they might be able to give you a different approach, be able to give you some more encouragement, some more support in the work environment to help you assist that client. Don't have to like clients to still be able to be effective.
Yes, and with the prior to the change of provider form, right, encouraging the client to talk to the provider first, to have that conversation. And then once they've had that conversation and they know that they've advocated for themselves, they've done their due diligence, right, really got out of their comfort zone, expressed themselves, if they're still feeling that it's not like there was no outcome, like outcome wasn't reached or the desired outcome, or they didn't feel heard, then I would encourage to fill out that form. And also when we're struggling, right, we're communicating with our, I second everything Audrey just said. And as we're learning, that may be coming up more often than we would like, right? Especially with the population that we serve, right? They have endured, right, life and many aspects of it. And it can be hard. Yeah. So please don't try to endure this alone, because it's probably that'll lead to burnout. We'll go more into that tomorrow, but we got to take care of ourselves, right? And if we take care of ourselves, then we're more able to take care of our clients and show up and provide the care services they need.
Thank you, ladies, for bringing up the conversation, because I think that's a really important one to have, and case management being the backbone and so much of all the other services that are going on. Really important to advocate for our clients and also help them to self-advocate and have these difficult conversations, because they're not easy to have, but can be so beneficial in that client trusting more in services and wanting to continue to engage in the future, whether that's with us or not.
So just a sidebar question. Who do I submit that to, Trish?
You send it to Trish and Natalie, and we can make sure that
Okay.
y'all have that form as well, the provider change request.
Well, I have one. They gave me one. They
Good.
gave me one. But yeah, I'll ask you about the rest offline.
Yeah, definitely. Any other comments to that or questions?
I just wanted to bring up a situation I encountered. A true story. It was a humbling moment for the client. I actually encountered a grand wizard of the KKK, which was he was blind. And the entire time he was talking, he talked about how he just hated the black race and blah, blah, blah. Not knowing, I never told him my race. But needless to say, we became the best of friends. And once I provided my service, I made it a point to let him know my race. And at that moment, it was a humbling moment for him. He turned every color. He turned every color there was. And I let him know, even though you demise and criticize my race, that did not deter me from giving you the care that you needed. He used to be a biochemist, and he fell in hard times. Anyways, I helped him locate his family. They ended up coming to get him, and they were floored to meet me and seeing that I was black, and they were just so in shock because in all these years he despised black people, and that moment he actually thanked me and hugged me, and they were just shocked. And he was 80 something. So it took all these years in that moment for him to realize, you shouldn't base your dislikes on color. But like I said, it didn't change the care that I gave him and the services that I provided.
Tanasha, you're talking about it was
Amazing.
very insulting, very degrading, very
Yes.
racist. How did you get?
How are you
in
able
that
to
situation?
do that?
Yeah.
I separated the two. I'm here to do a job. And like I said, he grew up in his lifestyle. So this is all he knew. So that's why I continued to help. And I made it a point to let him know, that it was a black woman helping you. Even though you talked about, you used the N word and all this, it never deterred me from helping. I still gave you the services that you needed. So I said, don't base everything based upon color.
Yeah. Sounds like you really compartmentalized that. Yeah. Lots of applause. That's,
Thank you.
I imagine, almost unbearable to do.
Yeah.
So glad you had that outcome that you had, and hopefully a really big learning opportunity for that individual.
Definitely.
Yeah.
Definitely.
And that's where I do want to support as well, because you're talking, it's a hard line to walk. That is a hard environment to be in every day and working with that client. And so you're not wrong in going to a supervisor and saying, this might be too much for me. We can request a transfer, right? We can make those in those circumstances, knowing our own limitations, knowing if it's going to be harmful for us or for the client in those situations, I think takes a lot of self-awareness. And it sounds like for you, Tanasha, you were able to navigate that line.
And also for therapy, right? If I'm going to my clinical supervisor, they may make me keep them as a client for therapy, right? To work through my own discomfort, right? I know Trish, I'm like, I can't do it. I can't work with this individual. And she's like, well, you're an intern, figure it out. And then we could talk about it on how, what are the barriers, right? What am I having conflicting beliefs about, right? Talking that out. But man, she didn't let me do.
I think she's eased up on that a little bit. And it's like, yeah, I think we can make that adjustment.
I'm like, can we just have accommodation? Yeah. Thank you so much for sharing your experience. I don't think I'll ever forget that. Holy, and I have respect for all of you, a case manager, each one of you, but you've elevated yourself there on that one. We are going to, did I cut somebody off?
No, go ahead.
So we're going to go on break. One last one. We will meet back at 11:24. And we'll wrap up. We've got one more half hour and then just a few more hours tomorrow, and then we're done with this part.
Oh, I've never heard your phone ring. That was funny. I'm like, her phone works?
Right? All right, you guys. So like Audrey had said, right, always talking to our clients that we do discharge after services, that it will be coming, that services aren't forever. So really having those conversations beforehand and going over that intake paperwork, right? And informing them of what could lead to a closure or discharge, right? So that when it does happen, it's not a surprise. Even if they say it is, if we adhere to the same policy and procedure and process with every client, we will know that our due diligence has been done because that's what we do. And if they're saying something else, then the odds are really low that what they're saying is accurate, even if they're, upset at the moment. So if we just have a process and we streamline it, then we can adhere. Like, no, that's not our process. We include that, so that most likely isn't true. Oh my gosh, true or false?
All right, quiz time. True or false? A patient can still retain RMH services if the patient is engaged in a therapy group only.
Go ahead and put true or false in the chat.
Yes.
It's really fun and interactive. Come on, guys, let's go. Just do your best guess. There's no one's getting penalized.
I'm sorry, I was dealing with a client. You want us to answer these
Yep.
questions?
Answer true or false for number 1 in the chat, please.
Number 1 is true.
So a couple trues.
That's a good question.
Still waiting from responses from Nicole and Janet. And Shanita, yes.
I'm not sure how to chat.
There's a little text icon. Do you have that? No. Interesting. I don't know why that would be. Are you on like a cellular device?
Yes.
Okay. Okay. Do you just want to share out loud, Nicole, what you think that number 1 is?
True.
True. And Shanita's saying if you turn your phone sideways, you might be able to see the chat feature. No. Okay. And Janet, are you able to respond to number 1?
She is on her cell phone too, and if I can't see it, she probably can't chat.
Okay. And Janet, you are muted as well, so I'm not sure if you're trying to say something.
Yes, I was saying I can't see it.
Okay. Okay, no worries. You ladies can answer out loud. All right. Yes, good job. Number 1 is true. Oh wait, I'm so sorry. Number 1 is false. False. If a client is in group therapy, they cannot do RMH services. That one's a little bit tricky. No, it's not true. They have to be in therapy, individual therapy.
At least once every month.
Yes.
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 But that's all right. Right? That's how we learn. Next one. If we have enough units remaining after the end date of the prior authorization, we can utilize them and continue to meet with our patients, client.
True or false?
The end date, we can utilize it.
Seeing some falses.
True.
So heard one true, couple falses. Any other answers for this one?
Mhm.
So the correct answer is false. You might be able to ask for an extension, but if not, false. Yes, we cannot go outside of a par. We will not be reimbursed for that.
Yeah, and just because there's units available, when they're only allowed, you can only use these units from this start date and this end date. And after that end date, those units fall off. Yeah, dissolve into the abyss.
Number
Sorry.
3, it is important to have direct supervision with a clinical supervisor before meeting each patient, as well as following up every 30 days. True or false?
Do we have anybody?
I want to say that's true because we had clinical supervisor meetings every week and we always discussed the patients, and then we had individual with therapists.
So we have Angela saying 3 is true. Shanita thinks it's false. Any other answers?
I kind of guessed too, even though I looked at the answers and went back. I don't think it's every time.
It's not
I don't.
with every patient.
Yeah, how is that possible?
Yeah.
But if that's so, we're
Clinical supervisor will never be able to do her job.
well.
But it's
Apparently,
yeah.
it's true.
Yeah.
So it's true. That's a best practice outcome. And absolutely the follow up every 30 days.
Yes.
True.
And there is, and you know what, actually, now that I'm that's why our direct supervisor and our clinical supervisor, right, they have a meeting, right, and then you're staffing with your supervisor, so it's all happening and then we have it all documented at our agency. Yay. 4, if you feel that it is important to include family members into your session, then you should proceed to do so.
Tanasha says false. Angela says false.
Oh, we lost Nicole.
Any other answers?
Dun, 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 dun.
False. And then lastly, it is appropriate for an RMH provider to see 2 patients at the same time as long as they have approval to have RMH services. True or false? Nasha says false. Natalie answered that one.
False.
False. Yeah. Good job, y'all. So this one is false as well, remembering HIPAA, right? So each client has their each respective, it also goes into respective units, right? One client's units are not the same as another client's unit. So this one is False. No go. Cannot do 2 for 1.
No.
Good job, everybody.
The HQ code, and that's what the PAR is for. But I have never seen anyone request a PAR for that. Yes. So making sure that we're adhering to what the prior authorization has requested, the billing code, and sticking to that and adhering. Any questions?
No, I'm just surprised at that last one because back when I was doing it, we were told that we could sometimes meet with clients together as long as they gave approval if they were working on the same goal. So if we were doing budgeting, it was okay to meet with both of them to do budgeting. I'm shocked at that one. This was some years ago.
Were
when I
there
was
more
doing
than
RMH.
one PSR worker doing that, or was it just yourself and 2 clients? What was the ratio?
It was me and my 2 clients.
Uh-huh.
And then the time that you billed for them, right?
Mm-hmm.
Was it, oh, one I billed from 1 to 3, and then the other one I billed from 3 to 5?
If we did 2 hours, yeah, I was separated.
Yep, that's called fraud.
Wow. So it should have been 2 hours for both?
Alone.
Okay.
You would have to divide that time.
Mm-hmm.
Right. That's why I said we would do 2 hours, but I'll bill 1 for 1 hour and 1 for 1 hour. But wow, yeah, maybe that's why some things we were taught were a little different.
Yeah, because it would say one-on-one, right? With the QMHA and the client, not with anybody else.
Oh, well, I'm a BST. I'm not a QMHA.
A QBA then, qualified billing.
Yeah,
That one. Sorry, but the one that qualifies for BST. Yeah. And just being mindful of that, don't
QBA.
work. Huh?
QBA.
Right, QBA.
Yeah.
Wow.
When I was in the field too, right? I had like 6 to 1. Not good. So knowing that what Medicaid chapter 400 is, adhering to policy and procedure. Yes. Okay, so I'm going to stop the recording for this one.